SIU on a lot of these things. We get many reports routinely, I wouldn't say daily, but weekly, on people stealing and defrauding in the private sector, never mind what we hear in the public sector. So it's not exclusive to the public sector. We have to get rid of it. So my last comment is the way to get rid of it is you simplify the system. If every one of us in this room, plus the car guards outside and the guy who's begging at the Fountain Circle in Pretoria, know that we will get the healthcare that we need, when we need, where we need it, without incurring any financial hardship, what is the motive to defraud the system? Right now, the motive is to get around the bureaucracy in the public sector, to get around the multiple layers of financing that we don't understand in the private sector. So I'm convinced as a public servant and as a public health medicine specialist who's worked for next year 40 years in the public service in Africa, that this is the right way to go. Do I think it'll be tough? Yes, it's going to be tough. Will it take a long time? Yes, it's going to take a long time. Should we start? Long ago. Thank you.
Thank you very much, Dr. Crisp. I know many of you are writing your questions down, and we'll give you an opportunity for that. The next will be Dr. Kgatlego Motudi. He is the Managing Director of the Board of Healthcare Funders, an industry representative body for medical aid schemes, so it just fits in nicely. Administrators and managed care providers. Dr. Motudi has previously served as medical advisor and clinical executive for Metropolitan Health Group and was the managing director for AIDS within the Afrocentric Health Stable before becoming the executive head of clinical services and operations at Sizwe Medical Fund. He has held various other roles in the healthcare industry, including working as a medical officer in the South African public healthcare sector, and later as a clinical manager of a district hospital. Dr. Motudi is recognized for his vast knowledge in healthcare management and business leadership, which has been gained over his experience in both the private and public health sectors spanning more than 26 years. Ladies and gentlemen, Dr. Motudi.
The difference.
I should have put it down.
Okay. Should I maybe just hold?
Where's the technician here?
Sorry. Right. Thank you very much, Honorable Singh. Let me pay tribute to the political leadership here, and I want to thank you for inviting us. I prepared a few slides. You will see that we are working in the same sector because we carry the same information with maybe slight interpretations. This is the areas that I'd like to cover. The direction that I decided to take was to just encourage us to look broader than just the bill, because there are many nuances that are often missed when we just look at maybe even just the technical issues. I will talk a little bit about those towards the end. But I want to say that healthcare is everybody's business, and it's very emotive because when you talk about it, and I remember, I can't remember, one of Dr. Crisp's colleagues was saying that beware of vested interest. And I want to declare that we do have vested interest, but not from a perspective of profiteering or preserving our environment, but because healthcare is very personal. And I was telling somebody, I think I was speaking yesterday at another gathering, that when you talk about healthcare, the first instance, I look at it from even my own consumption. I have chronic illnesses. I consume lots of pills every day. If anything is going to threaten my health, I will definitely look at it in a different way than from somebody who's from outside. So the point of departure, I'd like us to look at what else is happening with regards to healthcare. And most of you will be familiar with the Sustainable Development Goals. These are 17 goals that are proposed by the United Nations. And this is for sustainability of basically life, if I could put it that way. And every country has been encouraged to have this in place by 2030. I want to maybe reflect or ask you to reflect on a specific example. We were, Honorable Singh was referring to us chatting over lunch. We were talking about where we grew up and where we stay. I grew up in Hammanskraal. Now, 3 weeks ago I saw a meme or something like that. I think that's what it's called in social media. And they say that when you're going through a hard time and you think you're facing many challenges, remember that there are people who call Hammanskraal home. I'm one of them. And we are currently facing the challenge of cholera. Now, if you were to dissect it and say what the people in Hammanskraal and elsewhere are facing is just a healthcare issue, you'd actually be wrong. Because if you look at the sustainable goals, you look at issues of poverty, issues of hunger, healthcare is number 3, education, etc. Almost all of those actually led to maybe the current challenge. Because you asking somebody in Hammanskraal that I think since the early 2000s, they've been having very unhealthy water. My parents were living there until recently, and I used to bring them water because the water was not drinkable. Now, if you're going to ask somebody that, okay, the water is not drinkable, boil it. There's an issue of electricity. They don't have it. You ask them to buy it, they're not working. So almost all of those have an impact on healthcare. And what we're saying is that when you consider the NHI bill, don't look at it narrowly, look at everything else that is happening, because there are many other elements that actually impact healthcare issues. And of course, item 3.8 specifically talks about universal health coverage. And that's another issue that we say that when you look at NHI, the NHI bill, it is not universal health coverage, but rather a financing and purchasing model that will propagate us towards universal health coverage. I also thought it's important that to look at where NHI as a system sits in the pillars suggested by the WHO in terms of health system strengthening. If you look at the bars on your left-hand side, it's sitting at number 5. There's the financing element. But there are a lot of other issues that people complain. I was listening to the questions in the earlier sessions. People are asking about service delivery, infrastructure, availability of medicines, etc. And all of those things are actually important when you want to reconfigure healthcare services. I'm going to come back to this slide towards the end. So, universal health coverage, simply, you want people, everyone, to have access to healthcare services. But this must be services that they actually need, and essential services. They must be where they are, and it must be without financial hardship, and that is important. And there is a continuum of healthcare that you need to look at, from promotive aspects, preventative, and then when they are ill, they need to be treated. And if there are issues with maybe disability, you need to be able to rehabilitate them, and then also consider end-of-life care. Now, those are everything that you need to look at when you look at revamping healthcare system. There was a question earlier around the role of traditional health practitioners. And what it means is that if you are going to assess need, Those are things that you need to look at. So if I come from a village, Makapanstad, and arguably they say that almost 80% of people in, especially the rural areas, consult a traditional health practitioner before they go to a medical practitioner. Those are things that you actually need to consider. I was working in a hospital at some point, and we often had people that were admitted who had kidney failure, etc., because they ingested herbs, maybe without proper guidance, and they actually end up in hospital because there's no collaboration or discussions between orthodox practitioners as well as traditional medicine. So if you are designing a system for something, it cannot be exactly the same as what you are going to design for Makapanstad, because the need actually varies according to where people are. And those are some of the things that we need to consider when we talk about standardization, etc. And I'm not saying it's easy, but we need to have that in mind. The issue of right to healthcare, I think this has been spoken about at length. There's no debate about the need for us to revamp our healthcare system. This is enshrined in a lot of the Bill of Rights. I think there's 26 of them in the Constitution, and I think about 11 of them have got some inference to healthcare. So there's no argument. But a measure of true access, we think that is driven by largely two areas: the funding component, which is what NHI looks at, as well as the quality of care. So NHI is about organizing the funding and not directly involved. Although you purchase the delivery systems of healthcare, it is not directly involved with the delivery. So Dr. Crisp has spoken a bit about what the status of healthcare is. I won't belabor the point. It's a tale of two ecosystems, inequity, divided 85% and 15%, and that is state and non-state funded. There's an issue of a shift in the burden of disease. We've been talking about the quadruple burden of disease for a long time. We're still struggling with communicable diseases, HIV, malaria, etc. Non-communicable diseases are on an increase. So we need to factor that into those needs that I spoke about. Whether you're talking about diabetes, hypertension, the incidence of cancer, etc. We're still struggling with maternal and child mortality. I think in the next 2 slides or so, I'll show you some figures in comparison with other countries. And the issue of trauma and violence, and that's what we are dealing with. So the demand for healthcare reform is actually there, and it's increasing. But we also have a problem of increased trust deficit. And then that could be the point of where we are today. Because whether you're looking at people that are in the private sector, when they look at the state, their state counterparts, there's often ill feelings of how the other side runs, or what you are spending money on or spending attention on. In terms of the state, the issue of a perception of declining quality, we know that the infrastructure is under a lot of strain, and also there are major issues with the health workforce. On the private side, the industry is consolidating. But what I want to correct is the number of people that are covered in the private sector is not declining. It's been constant, around 8.8, 8.9 million. The biggest jump we saw was around 2003 when GEMS was introduced, and we had a bit of a bump, but it's been there. In 2005, I think we had more than 150 medical aids, and Dr. Chris confirms that at the moment we only have 72. But it's only the organizations that are running healthcare in the private sector that are consolidating, but the number of beneficiaries are actually staying the same. The cost is an issue that we cannot deny. We've got expenditure that is skewed in the favor of hospitals. If you look at the Council of Medical Schemes report from 2020-2021, 42% was actually spent for payment in hospitals. Now, I think there was a question here in the first session somebody was asking, isn't the private sector shooting itself in the foot because of this? But we've got structural issues. For example, the issue of prescribed minimum benefits. Those actually drive the high cost, or how schemes actually cost their healthcare. If you want to join a scheme, you need to pay at least 1,000 rand a month per person in your family, simply because you have to make provision for the 270 medical conditions that are supposed to be covered in hospital and the 27 for out of hospital. You can't cost it any cheaper. There's an issue of community rating. Medical schemes don't work like insurance companies, where when you are high risk, you have to be risk rated. There is a community rating. As a result, there is cross-subsidization. As a slightly older person, I depend on the younger people coming through. And at the moment, if you talk to people in schemes, there's a reduction of people that are younger that are registering. As a result, that cross-subsidization is actually struggling. And we are going to have an increase in these costs. Out-of-pocket payments, unfortunately, these are largely for primary care services. And I can also fall back on how schemes are structured. Simply because the bulk of the benefits would cover hospitalization. The provision for out-of-hospital benefits for many schemes is anything between 10 and 15% of the cover. And it makes sense, therefore, that as early as April, you may have people running out of benefits for acute service, because you have to make a provision for that. And I mean, I can give you an example of how this came about. When I was working in the public sector in the late 90s and early 2000s, before PMB regulations were enacted, it was not uncommon. I worked in a hospital called Jubilee Hospital. It was also in the news recently because of the cholera outbreak. We are about a kilometer or so from the N1 to Polokwane. Now, the worst time for a practitioner in the hospital to be on call is over Easter weekends, because there's a pilgrimage towards Moria. I think most of it, there's a gentleman who was there who said he's from Limpopo. What it meant at those times, we'd have lots of car accidents and bus accidents. And typically what you'd have people bussed in or with ambulances coming in. There'll be some sort of a triage when you look at those who are critically ill and those who can be treated fairly easily. Now, some of them would say, I have medical aid, and then we'll put them on an ambulance and they'll go to the nearest private hospital. It was not uncommon that 4 days later, they come back because their benefits would be depleted. And that was the rationale for PMBs. Now you no longer have that for these conditions that are covered. And that's why you have this out-of-pocket payment for the benefits that are not part of the prescribed minimum benefits. In terms of how the schemes are structured, they are very complex. The count of options for the previous financial year is actually 308, Dr. Crisp. And I'm on a scheme that has got 5 options. I don't fully understand what each one of those cover. I go for those that look like could cover what I have. So it is complex, and it's something that is not workable. And what I'm telling you was reflected upon by the Health Market Inquiry in terms of their recommendations. They were saying simplify the benefits, make them standard so that it becomes easier for the consumers to understand them. We've also seen an increase in primary care products or gap cover to try and pay for the shortfall. And I've also mentioned the issue of limited private primary care or preventative care benefits. The issue of legislation, there is some policy incoherence. We have these prescribed minimum benefits. There were recommendations from HMI. Those haven't been implemented. There's issues around the right of practitioners to practice where they want to, balanced against a certificate of need that was thrown out of court recently. We do not have a tariff at the moment. So a scheme every year sits down and says, this is, from our calculation, is a reasonable rate to charge. Now, Dr. Mzuga will tell you that in his rooms, he basically has to have a sheet for the 72 different schemes and knows that James pays 400 rand for consultation, but Paul Med pays me 420. It becomes very confusing as a practitioner, simply because in 2008, 2009, the National Reference Price List was actually thrown out of court because there was a disagreement between practitioners and the Council of Medical Schemes and the department. So the issue of health reform is something that I would say is not negotiable. We need to do something about it. I think the struggle is the how to do it, or what is relevant. And even in that, it's not so much on the what, it's the how to do it. I spoke about some of the challenges. Dr. Chris spoke about this. This was done, I think, in 2018. They compared South Africa to the 37 other OECD countries. South Africa is part of that organization. And they use these 8 parameters. Now, if you start at the top, the first one is the health worker rate. Now, just to explain how it's how to read it, the circle is actually the average from the 38 countries. The squiggly line that goes in and out, those are the South African numbers. Now, for those areas where the line is within the circle, it means we are doing poorly. The worst performing nation will be right in the center. And South Africa's performance, you will see towards the top left, the percentage GDP, we are almost on par with what everybody else spends. But when you look at, for example, the adult mortality rate, we're doing very badly. The infant mortality rate, we're doing poorly as well. As a result, our life expectancy is also not good. We don't have enough workers in the system. We don't have enough hospital beds in the system. The only area that we're doing better is the out-of-pocket spending. And even that, arguably, may not be correct, because some of the data comes from medical schemes. They look at the percentage of claims that were rejected, and that determines that. We do know, however, that the Stats SA tells us that 45% of households report that at least one of their members uses the private sector as the first point of care. And about 22% of people actually use the private sector as a first point of care. And I want you to balance that with what we report from the medical schemes about that 85-15% split. It is not the complete picture. What it means is that there are people that do not afford medical schemes who are spending whatever little money that they have still on the private sector, and largely because of the overburdened public sector. And those are some of the things that you need to look at. I don't want you to focus on any of the details here. I just want to show you how complex our industry is. On the right side, you've got the payers and the regulators more in the middle. The NHI, from our assumption, sits somewhere in the middle, just under the Department of Health, next to the provincial departments. And on the right side, you've got those who provide healthcare services. Now, most of these entities are directed by some sort of law. What it means is that when NHI is implemented, or even at the moment, there's a lot of points of interaction. And those are things that we need to be careful of in terms of, for lack of a better phrase, overstepping of legislation or the policy incoherence that I spoke about. Each of these entities or will be affected by the NHI. And it's very important that from a technical perspective, we must make sure that we tick all our boxes and make sure that everything is aligned. Now, this is how healthcare is funded. I won't spend a lot of time. We've spoken about the two-tier system. On the public sector, money flows from Parliament. There's an equitable share that eventually goes to the departments to finance services through the hospitals and clinics. On the private sector, largely covered by schemes. There are people who are paying from their own pockets, and from both ends of the spectrum. There are people who are rich enough not to take up medical aids because they can afford to pay for their own care, and there are those who don't afford medical schemes but still pay from their pockets, as I've mentioned. And also there is some that is provided by the employers. This Dr. Anban Pile, when he was still doing rounds around 2019, used this slide just to show the divisions in terms of funding, employment status, and this is the South African population that needs to be taken care of in terms of our healthcare reform. The proposed reconfiguration is also a busy slide, but what I want to take you through this thing. If you focus on the left-hand side, those are the facilities as well as the practitioners. The top ones are those that maybe would not want to take part in the system or do not qualify, and they are not accredited, and then the ones at the bottom are those that are accredited. If you look at the green people to the right of the center, you have those that are called users. There are those who may not qualify, who are non-users, and there are various categories in this realm. And then the NHI with all the committees and the governance structures on the bottom right-hand side, and then also the treasury. So the complexity becomes a bit better, but it is not completely removed. And you'll see maybe in the last few slides where some of the concerns still lie. So the bill has gone through the various stages. We know now it's sitting in NCOP. It's about to go to the provinces for discussion. There were about, I think, 138,000 submissions, Dr. Crisp, and I think 117 of those actually presented before Parliament. I don't want you to focus on any of the details. I just want to show you the top row and then the column on the left, just to show who participated. We had representatives from academia, business, community representatives, the councils, those are the statutory councils, funders like the BHF, the providers both in the state and the private sector, various associations. And there are certain concerns which are grouped into themes. The first one, of course, was whether they did say they were in support or not of UHC or NHI, and whether there is some sort of conflict. And the conflict issue is about whether they have lobbied for participation. Then you've got governance concerns that were sounded. There were questions around financing and coverage, the rollout and timeframes. There were issues around operationally how to configure the fund, and then the technical matters, which includes commentary on legality of some sections. When we analyzed this, there was overwhelming support for healthcare reform towards universal health coverage. Now, about 72% of the respondents that were looked at either were unclear, or support was conditional, or there was an outright no. From these, this is the division of their commentary. Most of them were worried about the governance issue. And in there you can pack issues of corruption, for example, that were sounded, and whether it will be run successfully. There were many questions around how this will be financed and whether the benefits would be adequate, operational matters, etc. But also, just over 11% were querying at a technical level, and mostly those are on the legal matters. This talks about constitutionality of some of the sections, the legal language that is used there in the bill. So this is just a summary of some of the comments. Under the constitutional matters, it actually affects almost all the stakeholders, whether you're looking at practitioners, the medical schemes, as well as the risk to the actual implementation of NHI and attainment of universal health coverage. Under constitutional matters, the issue around whether we're going to have a single purchase or single payer model, is there an infringement on the Bill of Rights, and this could be the right to access of healthcare. I think, Honorable Singh, you're talking about the stronger and the weaker. I think that's one of the questions around access. I know Dr. Mzuga, for example, might want to comment on the issue of the practitioner's right to practice their craft through the issue of accreditation and contracting, certificate of need, etc. Those are some of the issues that have been raised. The role of medical schemes, there are 3 clauses. The first one is 6.0, and then clause 33, and the last one, which is not included here but is in the later slide, is clause 57 under the schedules, where schemes are said to provide only complementary cover. I won't go through everything. These slides, I've given them to the researchers. You can look at the various elements, and maybe some of them we can discuss when we do the Q&A. So specifically the issues for medical schemes, the issue of complementary cover. Now, when you look at the definitions, there are certain challenges that arise because definitions may not necessarily be clear. And you might have a challenge in terms of translation of policy intent to legal language. For example, if you're saying the benefits will be comprehensive, how comprehensive is comprehensive? Is it something that is immediately clear? And if you're saying it's comprehensive, what then is complementary? Okay, should I just finish on this slide and then we'll, yeah, okay. I think maybe I must stop here, Honorable C, because it follows up to the next one, and then I can give over to.
Sorry about that, colleagues. Dr. Mzukwa has a flight at 4:45, so he has to leave here at 4:45, which is in the next 10 minutes or so. So I had to pause Dr. Matudi to give him an opportunity to address us. He is a general practitioner, practicing in private practice in Durban for more than 10 years, obtained his medical degree at UKZN, currently studying towards a Master's of Science in Diabetes at Warwick University. He's a member of the World Medical Association, served in the council, and he serves as a chairperson of the South African Medical Association as a board member of the Foundation for Professional Development. So, Dr. Mzukwa, I know you're going to avoid and evade all the questions that may come, but let's see how you can do. And just perhaps, give us a summary of the challenges from the association, from the practitioner's point of view, so all of us can hear about it. Thank you.
Thank you very much, Honorable Chief Whip. I'm not sure if you could quickly put my slides there. I'll quickly go through them. Just choose, I'll choose the most important ones. Let me acknowledge the leadership of the IFP and Honorable Hlabisa. and the Chief Whip. Thanks for inviting us to this engagement. Maybe perhaps let me just quickly start even before. we do support the universal health coverage as envisaged by the World Health Organization. That talks about all the services that were mentioned before. We're talking about promotive, preventive, treatment, rehabilitative, palliative. But it says all those services must be of good quality. It says also they must be safe, they must be affordable, and people must have access, obviously. When we talk about access, I think that's the major issue that we're talking about. I think previous speakers have covered issues, especially my colleague Katlejo, talking about the other 5 pillars or the other pillars of the healthcare system, which I think it has been a bone of contention with the Department of Health to say, when you're talking about the, overhaul of the healthcare system, don't choose one aspect, talk about the whole system. If you talk about the whole system, then you know that there's governance issues. We know that the health ombuds have been saying a lot about that issue. There's the issue of access that I think we are not talking about. When we say universal access, I mean, come in 1994, we're promised a very, very basic service or a very basic need, and that is water, access to water. And we got these reassurances that all of us will have water. I was born in the Eastern Cape at a small town called Flagstaff, in the eastern part of the Eastern Cape, the former Transkei. My village does not have water even today. My village doesn't have water. We depend on the Jojo tanks and the rivers. And now must wag a tale of welcoming when I promised this big NHI thing, when a basic need has not been delivered by government. Well, the other thing is we've been talking to government since this was started with the green paper, the white paper. We've made submissions all the time as the South African Medical Association. The honest truth, I know I'm not blaming Chris because he's a government official, but from the portfolio committee, we've never received a single response. The whole medical association, I mean, countries that are serious about the healthcare, they never leave medical associations behind. But the whole medical association that is holding about 12,000 members has never been engaged. There has been never, even our response, I mean, we've even made an oral presentation to the portfolio committee. There is no response, nothing. And you call that an engagement. We are not engaged, you are being told. Okay, can we move the slides, please? Oh, sorry. Oh, sorry about that. Now, Sama is representing also not only the private sector. I think I want to emphasize that Sama has a footprint in the public sector as well. So we have members in the public sector as well. And like I said, we agree with the concept of universal health coverage as it was emphasized by Dr. Crisp. We obviously are raising concerns as it relates to the question that is raised in this engagement. Now, if you look at what we're talking about is covered around Section 33. It says once the national health insurance has been fully implemented. So there's an understanding that there will be a phased approach in terms of implementing the NHI. So we don't know when this will be fully implemented. I think it's one thing that we we know. But also the issue of medical schemes. If we are saying, like it was covered by Dr. Mutudi, to say we don't know when you say those that are not covered by the NHI. I want to talk a bit about that. I think it's covered on my slide, the next slide now. We're talking about what we call cosmetic surgery. If you, for example, there are things that have been designed in the healthcare sector that are only designed for men. For example, the attention to breast issues. If a woman comes and says, I've got very large breasts, can I have this reduced? I mean, even with medical aids, you've got to write a motivation. But this woman is telling you, this is unbearable. These breasts are too large. They need to be reduced because they are affecting my back. What is cosmetic to government is not cosmetic to the ladies. So those are the issues that people should understand. When they design these issues, they must remove the patriarchy mentality. So I think when you say it's cosmetic, who is it cosmetic to? Is it cosmetic to the funder, or is it cosmetic to because psychologically it is a matter. It affects, the self-esteem of that person. It has got physical implications. It's not a nice to have thing to remove those, to reduce those breasts. Now, the other thing that we talk about, for example, is the issue of other procedures, for example, that are not be covered. Essential drugs, for example, we know we have got a serious issue of essential drugs. Even at times as practitioners, we've got to fight with the medical aids to say what I am giving to the patient is what is recommended by the guidelines. Rather, and that's what brings in the issue of co-payments, because a person would say, I rather pay than to get what is not recommended by guidelines. So even with the state now, sometimes what they do in the state, sometimes they get people who are academics, who are sitting there, who are not in the practice of medicine, and make guidelines. And at times, I mean, in most cases, some we've forced ourselves to be there. Because we said, we cannot allow academics to tell us how to practice medicine. Because we are guided by all the evidence that is out there. So those are the issues I think we've been raising as the Medical Association. What is it going to do to, maybe let me talk about this because you've already spoken about this, Dr. Mutudi. Let me just concentrate on what is how is it going to be affecting the doctors? When there's uncertainties, as it was said before, there's uncertainties on how this is going to be affecting doctors on the ground. For example, the NHI caps, for example, now, if you look at the provinces, Dr. Nicholas Cripps would be talking something different on the national level. But in the provinces, practitioners are being sidelined. We don't know as we speak how specialists are going to be contracted. It is not clear as we speak now. Benefits have not been defined. What is going to be covered by the NHI? What are the benefits? It's not been defined. Also, there's the private sector, or the doctors out there, they've got employees. Hospitals have got employees. If there's this uncertainty, you tend to have these people who are not sure what is going to go on, and they leave to other countries. Now, we have been told by one of the ministers, I won't mention him because it's not personal. He has told us, Sama, you are fear mongering. That's what they tell. When we told them, no, people are uncertain of what is going to happen in this country regarding NHI because there are no details on the bill. And people said, no, you are fear-mongering. And now we have stats, we have names of people who have left the country already. Because they said, no, we can't wait for this thing. We've got to be certain about our future. We can't gamble about our future. Now, practitioners are human beings who must think about these things carefully because they are going to affect them. Most of the politicians who are pushing these things are not treated in South Africa. They go to Russia when they need treatment. They go to Cuba. Their children are not studying in South Africa. They are studying abroad. So it's not going to affect them. So we have to have a voice. If there are issues that are not addressed, we are going to challenge them. If it means going a legal route, we are going to do that as a medical association. So I'm saying, especially because we've never been engaged. So if we're not engaged, then we must do that. So those are the issues that have been raised by colleagues on the ground. Issues that are affecting doctors. I mean, if you're not sure how you're going to be paid, we know, for example, that when it comes to payment, government is very poor with that. Service providers, in government for now, you're supposed to be paid within 30 days. But sometimes it goes even more than 6 months without receiving any payments. And you'll be told, no, wait for us, we'll pay in, some service providers were told in KZN, no, we're going to pay you after April because we don't have money now. Please don't stop supply in our hospitals. We are going to pay you in April next year. That was last year. So how do you survive as a practitioner without that assurance, with this track record? The last part on my side is the issue of trust deficit that is out there. I'm told that, we must trust the system. There will be no issues. Just relax. There will be issues on the ground. I remember during COVID-19, I saw the state president standing before us and begging for the Solidarity Fund. And the state president said, there will be no corruption with Solidarity Fund. That was before it was introduced. Days later, the president is signing proclamations to the SIU for people who have embezzled funds from the COVID-19. The same president who's been reassuring us. So this empty reassurance is what we are about. To say we support the system, but not, if you don't tell us how you are going to protect the NHI fund, forget it. We're not going to support it. Thank you.
I don't know why you reserved the largest response for Dr. Mzukwa. But Dr. Mzukwa, I just want to find out whether it is possible for us as the party to arrange a flight change for you. If that is a possibility for you personally, I'm sure we can do that. Pastor Ruben is here, our logistics manager, who's very good in all of these things. If you can take a later flight and if you don't have commitments, I think the three of you being together will really put our minds at ease here about some of the challenges moving forward. So I'm just asking that question.
It's okay, and the shuttle as well.
Okay, and the shuttle. Okay. So Pastor Ruben, our logistics manager? Joy? Or is he outside? Oh, no, Dr. Chris will give him an injection, yeah. You said you'll put him away, Doc.
He needs a hotel overnight too, because he's going to be and breakfast.
Yeah, I think Pastor Ruben will come and speak to you now and try and sort out the logistical arrangements. No, thank you for that. So I think before I kind of bring out some of the buzzwords that we heard in the conversation, I must give Dr. Matudi an opportunity to conclude his presentation, and then we can take it from there. And just to ask you gentlemen that have made these presentations, they are made available to us. Can they be made available publicly? Is there no problem with that? Okay, thank you. Haley, you taking note of that? That we could use these just to enlighten our other members, because we've just invited a core of people here today, and people from Gauteng were here, but just for others to have an understanding as well. Pastor, I hope you're not on a flight. Please come and sort out. Oh, is he coming? Right. Dr. Matudi? Thank you.
I need to be reminded where I was.
Can we go back to the slide?
Okay, there we go. Yeah. Yeah, so yeah, we spoke a bit about clause 33 and 60 and around the limitation of benefits that schemes can provide. I just want to talk about clause 57. I think clause 57 is under the schedules and includes laws or acts that may be repealed or amended. Now, in our understanding, while clause 33 talks about the change in the medical schemes environment when fully implemented, clause 57 though becomes active immediately on signature, and it actually gives the powers to, I think it's the registrar, you can correct me, Dr. Scheme, the Register of Council for Medical Schemes, to actually amend the Medical Schemes Act. And in our opinion, that actually may supersede clause 30. I see you shaking your head, maybe you will correct me. But that's our understanding from a legal review. So the key issues, I've already spoken a bit about the key determination of benefits, and also that the impression that is given is that there'll be almost like eventually unlimited healthcare benefits. Section 27 of the Constitution talks about to the extent to which the state can actually afford. And this talks about rationing of benefits. I don't know of any place that does not ration benefits. Medical schemes do. In the state sector, there is rationing, and this is usually through waiting periods, etc. I think earlier we heard of cataract surgery being delayed for about 2 years. We've had parliamentary responses by the minister indicating that some of the surgeries are delayed for about 5 years, etc. So there is a form of rationing. And I just want to make one example of where there is a lack of clarity on what some of the provisions in the bill makes. What is complementary cover? Does it mean the benefits, there'll be a basic package that is offered and it's then top up? Or is a top up also alongside what is offered? Or you've got benefits that are offered regardless of the level of care, and the complementary is alongside whatever else is not being offered, or is it a stepwise approach? And I think for as long as there is no clarity, and I think one thing about the law, we should not have different interpretation. It must mean one thing. For as long as there's going to be a need for clarification on the technical issues, it becomes difficult. For beneficiaries, I think the main thing that has come up is around what it means to the pockets. Are you going to spend more money? Now, it makes sense from the way the narrative is around the bill is that before there is full implementation, there will be a mandatory taxation from anybody who can afford to pay, while you are still financing your own cover through medical aid. There has been an indication of where the money might come from, but obviously we have to wait for the money bill. But there's talk of reallocation of tax credits, estimated to be around, I think, 30 billion, general tax revenue, payroll tax, etc. And I just want to maybe show the worry around the quantum. Just looking at in 2020-2021, this comes from the South African Health Review. There was a total of about 540 billion rand that are spent in the healthcare system. Now, two main issues around the shifting of funds, around the provincial equitable share being shifted into the fund. And I think that's where it might be, and Dr. Chris can clarify, if there are concerns around the constitutionality of that, because Section 214 talks about, of the Constitution, talks about the equitable share. Secondly, the issue around contributions from medical schemes. There is an assumption that this could also be shifted, while this is actually after-tax contributions. We do acknowledge that there is money that comes from the government to subsidize government employees who are on schemes, as well as the tax credits that are paid afterwards for those people who pay taxes. But that comes to under 100 billion from our estimation. But if we are going to cover the healthcare services that are supposed to be moved from everywhere else, including compensation fund, maybe some also from the road accident fund, we're actually looking at a bill that is probably north of 400 billion. So there is a deficit that we definitely have to talk about, but there is no certainty on this. So if we assume that, let's say there's 150 billion rand or 200 billion rand that needs to be financed from somewhere, it will definitely place a burden on those people who are already paying taxation in other instances. I've had commentary that the payroll tax that may be level could be in the order of about 5%, with a split of 4% to employers and about 1% to employees. But if you look at the numbers, last year SARS collected, is it 2 trillion rand? And then paid back around 380 billion rand. So net is about 1,600, also 1.6 trillion. What it means, if you look at where that money comes from, about 35% comes from personal tax. It's about 600 billion. And then the next bracket is the VAT, which is about 25%, which will be about 400 billion. And then company tax is another 20%, which will be about 200 billion. Now, wherever you place it, an extra 200 billion collection is actually a big jump. Whether you're placing on personal income tax or even if you spread it. I don't think there's a mention on VAT because I think Treasury doesn't have to ask the relevant ministry about the imposition or increase on VAT. But I can imagine that you would want to place further burden on the poor to finalize this. And I'm just raising this not because there are answers, but just to show that there is a need for clarity and consideration of how we position this the bill and how it will be funded. Dr. Zuka has spoken a bit about some of these things. The issue about role definition, who is primary care providers. Some people have asked, I use a physiotherapist, for example. Does it mean that before I go to my physio, I must always go to my a practitioner who's designated for me, etc.? The issue of accreditation and contracting. When you look at the B bill, I think accreditation is mentioned maybe in about 36 of the clauses. there are some areas that are confusing, even to the extent that some of the definitions are not in line with what is contained in the National Health Act, for example, and that might pose a problem. I showed you that very complicated slide of the interaction among the various players. These laws must be able to talk to one another in a way that will make sense. The issue of reimbursement arrangements, I think Dr. Mzuka has spoken about that, and also the complexity of the new environment. Does it mean that there are going to be set-up costs for practitioners? How much would they need to scale up in terms of their participation in the NHI? So other discussion points, I think I've mentioned quite a number of this, that when we talk about a comprehensive overhaul, we should not restrict ourselves just to look at what the bill says. There are many other things that would be expected for us to consider. We've spoken about infrastructure, healthcare, health workforce, etc. The state responsibility around the purchaser provider split. Does the bill actually achieve that? The argument around single and multi-payer system, whether it brings assurance in terms of how money will be handled, the inefficiencies that were spoken about, are they completely eradicated? And is the multi-payer system completely unworkable? And those are some of the debates that you need to look at. The governance concerns that we spoke about, those must be looked at, and we must ensure at the end of the day that the policy intent is actually addressed and translated into the act. I just want to, maybe in a minute or two, just coming back to this slide. During COVID, when you look at how we as a country handled the vaccination program, and I don't know whether it was by design, Dr. Crisp, or not, we somehow find ourselves following this framework, where if you look from the bottom, the leadership and governance area, we had the ministerial advisory committees, we had the collaboration between the sectors, and I'm not just talking about within healthcare, with the DTI setting up the demarcation regulation, not demarcation, DMA regulations, etc. So there was a lot of collaboration and talk, and a lot of leadership was actually demonstrable through what we did. In terms of financing, we had virtual pooling. The private sector, the employer, so you had medical schemes, you had employers and the state, all of them paying for vaccines. The end user could not tell the difference. If you went to Alexander Clinic or Santin Medi Clinic, the process was almost the same. And you did not have to pay at the point of purchase. Everything else was happening in the background. There was some sort of harmonization and interoperability. The issue of the medical products and vaccine, SAPRA was very prominent. We had a lot of fast tracking of issues, but there was communication between the various players. Information, we had NICD being upfront about everything. We knew at any one time how many people were infected, how many people were testing. There was collaboration between the schemes, NHLS, etc. Health workforce, we also saw contracting between government and the private sector, the use of facilities, etc. And that's a model that, in a very short space of time, actually worked. Was the system overwhelmed? Yes, it was. There were times when there were no beds, but everything was used optimally to the point that we could use it to. So, just in conclusion, there has been observations in countries similar than ours, where there has been collaboration between the private sector and the public sector, not just from a service provision point of view, but also from a funding perspective. And there are many commentators who are actually vouching for that. And I know Dr. Chris thinks that the UK example is not so relevant, but there are lessons that we learn. No two countries actually have the same system, but we can actually learn from what's happening. And all over the world, there is a growing demand for private sector support of government initiatives. And even in our country, in other departments. We're seeing, whether you're talking energy and other instances, there is a need for collaboration broadly. So the issue about NHI translating into UHC, I think, is important. We need to recognize that the discussion needs to be broader than just the bill. Otherwise, we will have a bill that's signed, but we don't see much in terms of the change. It's important that we don't look at a problem and throw money into it and think that it will solve issues. Dr. Chris told you about the American story, where it carries more money. The American healthcare system uses more money than anywhere else in the world, but they have the worst outcomes. Thank you.
Thank you very much, Dr. Matudi. I think we'll all relax now. I don't know if we'll need more water, Lulamile, for our panelists, because it seems they're going to do a lot of talking amongst themselves. Because I need to give them that opportunity so that they can clarify issues. There might have been some things that were misrepresented unintentionally, and I think we need to make sure that we're all on the same page when we move forward on this. But we just want to thank you sincerely for those submissions that you've made to us here. It really broadens the horizons for us and our thinking. Just by way of looking at some of the things that were said, yes, SARS is an excellent example of collecting revenue in our country. They do a great job. They tax you after death as well. And sometimes you pay more after death, your wife and your family, than when you were living. But that's the way SARS operates. But it doesn't mean if SARS are doing well. The big question is, what happens to the money that SARS collects on behalf of us, from us? How do we use that money? An experience in South Africa from 1994 and even pre-1994, colleagues, is the best teacher. We are not saying, Dr. Crisp, that that we don't have confidence in the system of collection and the use of money and resources. We know resources have been squandered. Resources in our country have been squandered, right? And then I always say to people that as a politician of 30 plus years, my view has always been that South Africa is flush with money. We collect enough money in our kitty, right? We are not utilizing that money properly. Taxpayers are not getting value for the money. When we say we've electrified 500,000 houses and provided water to 80% of our people, we could have done 160% and we could have done 1 million houses. Many houses are built and after 2 years they're rebuilding them. They're cracking, they're doing all sorts of things. Many water pipelines are just lying in KZN and other areas because the contractors have disappeared. There is no management. Government doesn't give us the hope, this government, that they can manage the funds that the taxpayers contribute efficiently and effectively. So that's what we hear on the ground, and I'm putting it to you, gentlemen, on that basis. We heard about the universal health coverage. I think we all subscribe to that. The single payer system. Now that frightens me. When there's the word payer there, you know, Zokokamali, Ntele, right? Zotatabani, Fapaketin, right? Sorry, doctor, you know. You know enough because yeah, you were in Africa for a long time. So the single payer system, if the main objective is to have a payer system that is managed by government, Ngak. Not this government, not any government, even if it's an IFP government. What are the checks and balances? Where is, right, we've got parliament that's going to oversee, and we say oversight. But in many instances, it doesn't become oversight. It means agreeing with the executive. And even things that need to be looked at with a microscope because of majorities, it just gets passed through. So when I say experience is the best teacher, this is what I mean. And these are views of people on the ground. The demand for healthcare reform, we agree. We have to reform, right? SAMA is not engaged. That's concerning, but maybe Dr. Crisp will say something about it. But I'm just saying this is what we had. SAMA has not been engaged. And we can't have 12,000 disgruntled medical practitioners in our country. I was speaking to our president, Bulawayo Tlabisa, early on. His daughter has qualified as a medical doctor. She's got no job. No job. Many people have qualified. They've done the internship. They're not placed. Last year, there was a concerted effort to boost the budget of the provincial departments, which we appreciated, because then they could employ doctors. But what's happened after that? What do these young doctors do? Right. Then this cosmetic surgery thing is a very important thing. And I'm telling you why, Bulawayo and leaders. This morning after I called my wife about 7:30, I was interviewed on a TV channel. She says, "Hey, but your chin was looking so big, it was hanging." I said, "You see," so I said, "You see, when my stomach goes big as well, then you snore, you do all sorts of, so I need cosmetic surgery, which is going to help me medically." So you used a good example of cosmetic surgery. And of course we agree that with medical aids, we have tremendous challenges. Those of us who are members of parliament here, we belong to PAMED. And even with PAMED being an independent kind of medical aid scheme that has been tailor-made for MPs and judges and magistrates only, we have serious problems. Halfway down the year, your medicine money is finished. So we have these problems. We are not saying that the medical aids are perfect. We're not saying the private sector is perfect. Because sometimes you go to the private sector, they'll charge you 2,000, 3,000 rand something, doctor, and when I can do it for 500 rand if I was a doctor. But you'll charge me 2,000 rand for a consultation. So we are concerned about that. How many of us can afford that kind of thing? We're concerned about that. When you look at the price of medicines, you go to the counter, they'll say this is 50 rand. But for medical aid, it's 100 rand. Why? And that's how our money goes down, you see. So these are some of the daily practical challenges. So in all of this, we see, colleagues, fears and aspirations. The society needs to be transformed. We can't, 30 years after democracy, say we haven't provided universal health, but we still haven't provided water for everybody. Right? We need to transform, we agree. So there's an aspiration to transform. The aspiration of the governing party to transform society and say to people who are doing things for you. But there are the fears of those like your doctors and others who are exposed to private medical health care. What happens? Simple thing. If I need to go to a doctor in future, Dr. Crisp, what happens? Who do I go to? These are the questions they want to ask us. I may be able to go to Santon Medical Center, even if I'm coming from Alexandra or Soweto. That's good. But where do we go to? What do we do? What happens to the existing medical aid schemes that we all belong to? So these are some of the things that I thought we'll just try and fire our panelists up to first answer questions, clear misinterpretations, and then I'll give them an opportunity and give them the mic to ask each other questions. Doctor? Yeah.
Just, I think I was rushing when I did my presentation, but there are other issues that I wanted to bring to attention as well. If we're talking about having good health outcomes in the country, then we cannot be talking the Department of Health or health alone. We should be thinking about other aspects, like, for example, what is called socio-economic. Oh, thank you so much.
Order, order, order. Honorable Slangwa. Order. I had to tell you that because you know what order means. Thank you.
Okay, thank you so much. No, I thought I needed to bring this to the discussion as well. There's what we call socio-economic and environmental determinants of health. Now, there's one aspect that I raised about water availability and stuff like that. And Dr. Mutudi already indicated how that impacts, healthcare. For example, in Hammaskral, there's issue of water, and then there's cholera, and those patients are going to be going to, those communities are going to be going to the health department of health department to, obviously, to get treatment and all those things. So I'm saying you can't be hoping for good health outcomes when there is a fragmentation in terms of those socio-economic and environmental determinants of health. They need to be addressed as well. So the issue of access that I was talking about, if you have, for example, people who are sitting without any healthcare institution, how do you expect those people to have access when actually there are no hospitals, there are no clinics around them? They have to run for about 4 hours before they reach to hospitals. Hence, we're saying, don't talk about money alone. Talk about how you deal with infrastructure, for example. Make the infrastructure available, to all communities. It must not be because you are staying in a city environment. Even if you are in the rural area, there must be a clinic, within a walking distance where you can access healthcare. So access must not be on paper. It must be real, in the communities. So that was what we are raising as the South African Medical Association. The last part was the issue of the health workforce. We know that the minister already made a declaration in Parliament that there's a shortage of doctors and nurses in the healthcare system. And we do not have a problem of production. We are having lots of doctors who are being trained even outside of South Africa. But the biggest issue is that we cannot place them, like you said, Honorable Singh, after community service. The department will tell you we don't have money. And in Limpopo and the Eastern Cape, they've been told by government to go to private. Yet they will, when they're making political noise, they will say, actually, the private sector is taking all the resources, including doctors. But they are being pushed by the system to say, we can't employ you. I was working in government. I was doing sessions at King Edward Hospital. It changes the name all the time. Sometimes it's Mqanga Hospital. Sometimes it's a no-name hospital, but the time when I was working there, it was King Edward Hospital. Yes. Then we're pushed out. We're told, no, we don't have funding. We can't take you anymore. So I am not sure what funding are we talking about when actually we are chasing those people now who should be, held in the system to fill up the gaps that we're talking about. Issues that have been raised by the World Health Organization. So I think those are the answers that we need. That's clarity we need. We can't just willy-nilly support the NHI without having those details in place. Thank you.
Okay, thanks very much. I have 2 pages of notes to clarify things that are either inaccurate or wrong facts or misinterpretations. So please bear with me on a few of them. First of all, to say thank you very much for the congratulations on COVID. I worked for an average of 20 hours a day for more than 6 months, making that all happen. And so thank you very much for the credit you paid to us for that. Perhaps I must start off by asking how many people in the audience here were born in the public sector? Or either at home or in the public sector? Nearly all of us.
I was born at home.
So I was born a long time ago. My ID number starts with a 5. So I was born in what is now Kumani in Queenstown. And I have worked in Limpopo for 15 years as a medical practitioner. And at that time, there were no private hospitals, none. I worked at Letaba Hospital. We had a polio epidemic in 1982. In 1984, I started to work there to deal with that. That was a water problem. While I was there, we had neonatal tetanus. I saw more than 1,000 people, including adults, with measles in one day. One day. And I have seen whooping cough, tetanus, neonatal tetanus, at least one a week, and typhoid. Everybody had typhoid. So we must also remember where we came from. So I was also the regional director of the old government under Rina Venter back in the period of 1989 to 1994. In fact, I left the government in 1993 and I went back in as the head of department in Limpopo in 1994. There was a deliberate policy in the 3 years preceding, during CODESA, deliberate policy to open up and create as many private hospitals as possible. I know this because it was my job to recommend or not to recommend hospitals in what was Northern Transvaal, today's Mpumalanga and Limpopo. Every one of our recommendations was overruled. And the reason was very clear. When they take over the country, which is most people in this room as when they take over the country, we need to protect ourselves because they're going to take our hospitals too. It was a very deliberate strategy to create a massive private sector. It doesn't mean it was right, but many things have gone wrong in that period. What we do have is some very good clinicians, very good health services. But we, including me, who's now in the public service and who's an honorary professor at the University of Pretoria, we are proud of our training. We are well trained in this country. We are very good. But because I work in the public sector doesn't suddenly mean I lost my IQ or my ability to participate in debates, and that some other professor who works full-time in a professor university or whatever is any better. We need to recognize the people who are in our public service are by and large, still highly competent clinicians. There may be some who mess up. But we need to be proud of what we do have. What the problem is we spend 5,000 Rand per capita in the public sector and 27,000 Rand in the private sector. Now, how do you expect to get the same service for 5,000 as 27,000? You can't. We spend 15% of government spending on healthcare. If you were to spend the same amount per capita on healthcare for everybody, we would be needing 1.3 trillion Rand to do that. So the question is, are we getting value for money in the private sector, and are we able to manage in the public sector? And the answer for both of them is no. We need to reform these systems. So I think we have come a long way. It has not gone the direction that we would have liked to see it go. So when I was still in the position as head of department in Limpopo, we switched from the transitional constitution. You will remember that one, the 94 constitution. And in 1996, we got this constitution where we got the section 214s and the section 256 of the interim constitution went out and so on. We have been through transformations before. But when fiscal federalism was brought in the 1996 Constitution and the PFMA was first drafted, we warned, you are going to create duplications and you're going to create a mess. So I think we do need to recognize the history when we start planning for the future. I want to first of all say, we all know about social determinants of health. I mean, I'm a public health medicine specialist. That's my job. That's what I've done in 7 African countries for the last 35 years. So we all know that. But this piece of legislation is not about everything. The Health Act is still there. All the other health legislation, Termination of Pregnancy, Pharmacy Act, etc., there are 30-something pieces of legislation we administer. They are all still there. There are minor amendments to the Health Act. Section 37A is one of them. And there are other clauses within Section 25 and 23 and so on that are amended in the schedules. But the Health Act is still there. All the environmental protection laws are still there. Everything else has not changed. The only pieces of legislation that are changed, and there was a question or a comment made, I think you made the comment, about which pieces of legislation, including the Medical Schemes Act, will be changed and the ambiguity. There's no ambiguity. Read the Schedule 1, and you will see what is amended in the Health Professions Act, Nursing Act, Allied Health Professions Act, the Health Act, the Medical Schemes Act. All the amendments that are in that schedule are what change on the day this comes into law. No other amendments are made immediately upon the promulgation of this legislation. Those, if we need other amendments to be made, even to the Medical Schemes Act, this is a normal process. You repeal pieces of legislation and you amend other pieces of legislation. So I would encourage you to go back and really see what is in the schedule to understand what is being amended at the time. We had a discussion about we don't know what's the role of the GP. There's been no consultation. There's been we were ignored, what. So with due respect, the people who made presentations to Parliament, written or oral, are not the only people in South Africa who engaged with the process. There's been a green paper, 2 white papers, and this whole parliamentary process. SAMA is not even the only medical association in South Africa. They've been through a protracted battle with SAMATU for different reasons, and we don't need to go into them here. But that's another voice that doesn't have the same views as SAMA. You will agree. They differ, they fight, they argue. We have different nursing associations and nursing unions and so on. They don't always agree with one another. There are many parties that have different views. So I can't speak for Parliament. Mahlengwa can talk about what happened. Honorable Mahlengwa has been there from the word go. She knows what happens in Parliament.
So don't speak for Parliament.
But, no, I'm getting to the point. You make comments that the people in this audience and on the media think that we don't talk to you. But you have members of SAMA who meet with me regularly. They come, and this week we had a meeting with some of your people. If you don't know about it, then they need to tell you about it. And they've been invited to the contracting units. Claude and Ndlovu and Lindy Shengi and the whole team, they meet with me from time to time, regularly. They are part of the contract. They get invited to the contracting unit for primary healthcare discussions that are driven from our department. SAMA is not the only one that does. I'll be next Friday spending the day with the GPs in KwaZulu-Natal at their forum. I've been to the Eastern Cape to meet with the Eastern Cape doctors. So I think we must be really careful when we say we're not consulted, we don't. If you weren't agreed with, or you weren't the only ones that got your voice ahead, well, that's how it works. That's how we listen. The trust deficit is a serious problem. And I'm afraid that's a societal thing. I work in the Department of Health, and I've got to the point where it's very difficult to trust just about anybody. Not in the health department, not outside the health department, not in society. So I think we all feel that at a personal level. Do I trust the police when I see them kicking someone on the side of the road? Do I trust Eskom for making statements that we're not going to have power? Do I trust? So I think we accept that. But it doesn't stop me as an official from believing that we can improve the health system and this is the right way to do it. And I think we need to stand up as South Africans. That's what I would appeal. And members of your party do stand up and often make these statements, and that's good, and it's important in the spaces that you have. I won't argue about private, whether it's declining or not declining. As the population's increasing, the number's been frozen for a long time. It's not a growing space, it's a difficult space. People are migrating packages down. Every week we speak to people who used to have comprehensive packages, can't manage anymore. They're now going to hospital plans, they struggle. It was 18.5% in 2017 that were on hospital plans. In 2019 it's 22%. We're waiting for the new figures. People are battling to pay for what they get. I, for one, have no idea what I'm covered for in my hospital plan. I've been hospitalized in the recent past, and so has my wife. And when we submit claims, how much of it do we have to pay out of? We guess. We don't know what we are going to be covered for what we are doing. It's not a happy environment. It's not an adequate space, and many of you have spoken to that. So we do need to do something about it. The PMBs are a big problem. We agree. There's been a PMB review going on and on and on and on and on. I am meeting with the CMS on Monday, where I want to know exactly what's going on in the space, because we have to account to the minister on what is happening. We agree. We don't have any difficulty with your comments about that. But what we do with it, how do we create a space where patients are encouraged to get outpatient care at general practitioners and not in hospitals? That's what we are trying to solve for. And there are several different solutions that different people push on that, and we will wait until we get the research before we pronounce on it. There was a mention made of the certificate of need and how we lost the court case. We did not lose the court case. We didn't challenge the court case because we didn't know about it. We were not invited to the court. We never signed the papers. So when the Pretoria High Court ruled on it, we heard about it in the media. So we challenged it, and the rescission hearing was in our favor. So now we will go to court and we will debate our case on the certificate of need. But that certificate of need was in the previous Health Act. Section 44 of Act 63 of 1977 was the certificate of need. I know, I was the regional director who used to administer it and make the recommendations to the minister. It's been there, always. The question is what we do with it going forward, and what are the intentions, and how do you plan? And so I think that one must be really cautious. If you don't know the whole detail, find it out, give us a call, talk to us. Don't say, I'll meet you in court and here's the court case and so on. That's not, all that does is make lawyers rich. Yeah, I'm always worried when we compare with OECD, but that was quite an illustrative diagram that was shown. It just shows that we do have massive problems. We don't get the outcomes for the input that we give. The diagram you showed on the proposed reconfiguration is very different from the diagram we have drawn in the department. So I think it will be nice for me to look at it and have a separate meeting with my colleague here to understand how you get to that diagram. It's much simpler than that. The governance issues we debated we listened while our honourable members of parliament debated the governance issues. So this is a conundrum. We heard on the news yesterday morning that the new Eskom CEO has been appointed and the announcement will be made in due course. Now, we would never do that. Even in the NHI space, there's a more consultative process in the bill. Even before the amendments, there was a more consultative process. But that's happened. So I think that the amendments that are in the bill are actually well thought through. I thought they were well motivated to make sure that the minister alone does not appoint the board and does not appoint the CEO, doesn't have anything to do with the CEO. And the honourable members of parliament made those changes. So I think that having the board being, finally the minister signs off on a board, like the Minister of Finance signs off on the appointment of the head of SARS, like the Minister of whatever signs off on every one of these agencies and boards. That's how it works, except for the SABC. And where are we with the SABC, where Parliament must appoint the board? These things are complicated. We do need to find a way that we're not held to ransom every time. So I think that what we've got in that governance structure, with the board being left to manage the place, with the board to appoint the CEO and the senior executives, that's what we would expect to happen. Section 33 is contentious. Let's be clear on that. What is fully implemented? What is not fully implemented? So what we are doing at the moment administratively is designing how do you get to fully implemented, whatever that might mean. What are the progressive steps? And the answer is you tailor your benefits to the money that's available at that point in time. So if you move only the conditional grants into the fund first, so it's 60 billion rand, of which 10 billion is capital, which won't move. But the remaining 50 billion are in a hodgepodge of conditional grants. Health professionals teaching and training grant, tertiary services grant, there used to be a forensics grant, and a so-called NHI grant, where none of it is anything to do with the NHI, by the way. It's all to do with health system strengthening. If we start to move those grants in, then you might have 50 billion to start off with. I would argue that's even too much to start off with. So you start with one piece at a time. Now you say we're going to cover these benefits with that piece. We're going to get our systems in place. Now the rest. And once you cover across the entire spectrum, then you give notice of 6 months, 12 months, whatever the requirement we agree on between us in the parties. And then the medical schemes must say, from this date next year, we will not cover this. They redo their evaluations, they redo their actuarial calculations, and they don't charge. Then the tariffs come down and down and down as we start to cover it through the taxation process. So that's the kind of way that you implement these things over the periods that we are talking about, 10, 15 years. Benefits will not be defined. If I ask any medical scheme today, what benefits will I get next year? They can't tell me. Because they're calculating all the time on what is the risk pool, what are the new technologies, what is happening in the let's call it the industry space. We don't call it an industry, we call it a service. What is happening and so on. So every year, I liken it to a tube of toothpaste. My medical scheme is a tube of toothpaste. This year, it's 120 grams. It's got white stuff inside it and a lid. And it says new on the box. Next year, I get 100 grams for the same price, maybe a little bit more. And it's got new, but a different new in yellow on the box. You don't know, because you don't anticipate what is going to happen in this highly complicated technological space. Not because I'm being critical, it's just how it is. So the other point about benefits is the fund does not exist. Therefore, the fund cannot publish the benefits. The fund will not exist until there's a law that allows it to exist. Once it exists, the president must use the Section 59 to begin to bring the clauses into law. So if I'm asked, which I am, which clauses do we bring in first? We bring in the creation of the board. Those clauses which deal with board and board functions and the ability of their board to go and source a CEO. Those are the first clauses that you bring in. You stabilize it. It might take a whole year to do that. Because remember, the bill requires that the minister must appoint an ad hoc committee to independently and openly, transparently interview candidates. That's fantastic. That's like the JSC. So, who serves on the ad hoc committee? Doesn't say so in the bill. We are busy writing that in a way that is absolutely transparent. We will table that, and we will put it in the public domain, and we will say this is how we envisage the ad hoc committee being appointed so that everybody knows who is going to interview the candidates that are nominated for the board. Then there might be 40 people who are nominated for the board. Who may be nominated? Well, it shows in the bill you must be in good standing, you can't have a criminal record, you mustn't have conflict of interest, and so on. But we need to be more specific of that. What is conflict of interest? Who are we actually looking for? How do we get the gender and the racial balance that is required in the bill? What are the ratios and targets we're looking for? Those are the policies that we are writing at the moment in order to implement just that one clause. This is how our law works. We write regulations. We've only ever had 3 health acts in the history of South Africa. 1919, 1977, and 2003. This will be the 4th piece of major health legislation, and it doesn't even repeal or replace the National Health Act. These pieces of legislation last a very long time, and they last because they can be amended in Parliament and because the regulations enable us to do things in them. When we talk about benefits, there are globally, so this is an area of public health medicine that we study around the world. You have approaches to either being inclusive or exclusive. So if you go to the website of the Ghana National Health Insurance System, you will, National Health Insurance, you will find that they have expressly excluded certain things. So they do have an inclusions list, but they have expressly excluded certain care. And they do that because they don't have enough money. So for instance, no cancer is covered in Ghana under the NHI. It doesn't mean you can't be treated, it just means they don't cover it under their NHI. They may have increased it. I haven't been back to Ghana for 3 or 4 years now. They may have included it by now. So that process of deciding what can we cover and what can't we cover is done through a process of, there are algorithms around the world, and we use health technology assessment. So if you go and look up the HTA processes that are run around the world, probably the most well-entrenched one is the National Institute for Clinical Excellence in the UK. But there's a brilliant algorithm used in the Philippines that we've been watching and working and talking to them about. And it's more like our kind of socioeconomic status and so on. So we're watching it. There's really a really nice HTA process in Canada. But it's a different world from ours, and so we can learn lessons on how to lay it out and so on. So building what is going to be covered by the fund as opposed to what's not covered by the fund is an ongoing process. As you heard, medical schemes do it all the time. We'll include this in this package, but not in this option and not in that one, because this is the risk pool and the money and the so forth. It's the same thing, except now we're talking about one set of benefits for everybody. There was no embezzling from the Solidarity Fund. There was a comment. There was embezzling from the state. We warned them. We told Treasury, don't do what you have to do. Remember, it's Treasury that did that. They opened up that procurement process in very fast and very, very open. We actually had better controls in the health space because we already managed these 1,200 more sophisticated and strategic medicines that we have. We wanted to manage it in that place. But the Solidarity Fund is private money. It wasn't government money. And Gloria and the others who managed that did a darn good job of managing the money. And by the way, they bailed this country out of trouble more than once. What many of you wouldn't know is we ran out of needles during COVID. We knew it was coming. We had ordered 80 million needles, but so had everyone all around the world. And the container was on its way to the port in China to bring it here, the 80 million needles. When we realized the 6-week voyage of all this other things, places this container would have to go to, we would run out before the container arrived. And Solidarity Fund chartered an aircraft and took a part load off of that container and brought it to us by air freight so that we never ran out of needles. That kind of collaboration is widespread. I've met with the Pharmaceutical Task Group this week and last week. We talk to one another all the time, trying to find better ways to do things. But we're only a small team. In fact, in health financing in the NHI branch, there are only 2 of us at the moment. And I think we get quite a lot of work done for the 2 of us. The bill makes repeated reference to progressive realization, systematic, over time and so on. And the Constitution also talks about progressive realization. So we mustn't have an expectation. You know, we keep hearing comments, the economy is too flat now. We are not talking about now. We are talking about a framework that must look after us for the next 20, 30, 40 years. And it may only start in 2 or 3 years' time. Once the bill is promulgated, it'll take a minimum of 6 months to get the board and all the board machinery in place. What about all the administration? Yes, we've done groundwork. We've got the digital system. We used the NHI's digital systems to create the EVDS with no additional budget in 3 weeks from scratch. That's the capabilities of the state that everybody doubts. Just in the Department of Health, together with our partners at the CSIR, I must say, have been marvelous. So where's the money? And you saw a table there with where the money is over the years and so on. And how do you move it? Well, you start with the easy ones, the conditional grants. You don't need new legislation to move conditional grants. You just need Treasury to agree to put it in a different way in the medium-term budget policy statement. And we need the honourable members of Parliament to approve the budget when the budget vote comes up. That doesn't require new law. It's 50 billion. To move provincial equitable shares, funds follows function. Section 32(2) results in the amendments to Section 25 of the Health Act, and Section 25 of the Health Act is where the provincial functions and the national functions are allocated. Those are not constitutional decisions. We shift functions all the time in government. We shift borders of provinces frequently. Well, we used to do it very frequently. Things change. That's not unconstitutional. The Constitution is not the Health Act. The Constitution just says that health services are a concurrent function. So if you amend the Health Act to say we're going to move this function out of the National Department of Health into the NICD, which we've just done, we've moved the forensic chemistry laboratories into the NHLS. You don't need, that's not a constitutional debate to move a function. Once you move the function, the money follows the function. So if you remove functions, not all of them, but some of them from the provinces, the money that is allocated to those functions in the provincial equitable share, move to the national sphere of government, and the bill says the minister must put them in the fund. So that's the second option, the second route, second amount of money. The same would apply to correctional services. Is it efficient to have a separate health system running for inmates? No, it's not efficient. Is it efficient to have the road accident fund appointing only private healthcare practitioners to look after people who are in road traffic accidents? No. There must be a better integrated way of doing it. So you move those monies, but some of them require the law or a regulation to be able to move them. The last one, no, let me get before the last one. The state employs round about 1.2 million people just in terms of the Public Service Act and the Police Act. Forget about the Defense Act and all the other pieces there, just those two. Somewhere around 1.2 million, not including municipal workers, not including all the parastatals, public entities, everything. 1.2 million people. And you and I as taxpayers subsidize their medical schemes through agreements in bargaining chambers, but we pay that money to medical schemes to administer. The state could make a decision to take that same money, the employer contribution, and put it in the fund and pay for the health care from the fund. They will still buy the care from private and public providers. So there are many routes. The detail of each of those needs to be defined, but the money is already there. By the way, that's 40 billion rand. The tax credits are 35 billion rand. So if I, as a private person, if you took my tax credits away, it would make no difference to me whatsoever. But it will make a massive impact to those who are dependent on the public sector. So why do we keep doing it? Why does the state keep subsidizing the private sector? Two more comments. We are fixated on trying to solve 10 years, the solutions for 10 years from now today. No piece of law does that. Our law is all drafted as enabling law. We know this healthcare is an incredibly complicated technological environment. Every day there are new discoveries, new vaccines, new implants, new this, new that, quicker, smarter ways, more cost-effective ways of doing things. So we do rely on university professors and the global space for evidence-based medicine to tell us what are the ways to do these things. That's exactly how it works in Australia, New Zealand, Canada, and every other OECD country. We are not unique. We are unique because we don't do it properly in our country. So I would just really like to appeal that nothing in this debate is clear-cut, except that we have a very messy health system. We waste a lot of money. We need to fix it. I'm still convinced, after spending many years outside of government and coming back in deliberately to help with the setting up of this process, that this is the right way to go. And I know that it's a long game. You do have to do these things carefully, gently, thoughtfully, and taking everybody on the way with you. But you can't start on the journey until you've got the roadmap in place. Thank you.
Okay. Thank you very much.
Allow free flow.
Yes, yeah.
Just go.
Yeah, I think there are a number of important points that came out from the comments now. I mean, I agree that we're not getting any value for money, but why? And I think there's a constant shift of blame to other areas. We acknowledge that as medical aid scheme, as a private sector, there are challenges, but most of the areas that you're speaking about are actually regulated by government. For example, the issue of tariffs. So we talk about the issue of increasing costs. And some of these things are well articulated in the health market inquiry. I spoke earlier about the issue of the national reference price list being scrapped. But that is the purview of government or the national department to actually set tariffs. It's actually under the DG's prerogative under the National Health Act to actually set up structures that determine tariffs. We've spoken about the issue of PMBs. The regulations say this must be reviewed every 2 years. PMBs have only been reviewed once, and the regulations promulgated. They were introduced in 2001, and the first review was the inclusion of HIV as another CDL law. The current process that we are talking about is 6 years running. So we can't judge it, there's no output. So there has been no review, and it's under the government responsibility to do that. There's another matter that you and I don't want to talk about, the low cost benefit option. 2015, demarcation regulations were promulgated. We are still waiting for the regulations. We are now contesting it in court. I'll leave it there. During the HMI hearings, and I remember distinctly, former Justice Sandile Ngcobo asked the former minister why PMBs were not reviewed. And the answer was, because we are working on NHI. Now, I want to bring in one of the other comments that you made, that NHI is just one part of a number of elements, but it's been loaded, and the minister actually said that this is the most revolutionary piece of legislation that has ever been regulated. And it's actually promoted as such, but we can't belittle it now and say it is not as big as it said, while government has actually held back other reform initiatives because of NHI. The issue around ambiguity in the laws. The challenge that we have is that even within the proposed bill, there are certain sections that don't talk to one another. And I think a lot of the comments from a technical point of view actually point to that. And I think this is what part of Dr. Mzuka is talking about, that comments that have been submitted haven't been listened to. I mean, we listened to the department's response, I think maybe a day or two after conclusion. I don't think there's any way that all the 135,000 comments would have been assessed during that time. And there was just dismissal, the same way as the comment around the constitutionality. Even the parliamentary advisor, legal advisor, and the state legal advisor were not in agreement. But that was not even considered. And those are things that we are saying, Dr. Crisp. Listen to the commentary and be seen to be considering them. And then you will garner support from everybody else. It looks like there's just a railroading of the process to achieve this without any consideration of anything else. I think you've heard from our discussions, and I think elsewhere, there's an overwhelming support for healthcare reform. The challenge is in the detail. And when the department sits back and say, what you're saying doesn't make sense without having given due regard, that causes problems. And that's why there are many institutions, and I think Dr. Mzuka even says that they are talking litigation, and we don't want that, because once it goes to the court, nothing will happen for a long time. I've mentioned the issue of the certificate of need, not because I was commenting on its validity or not. I'm just saying that there's policy incoherence because there's no dialogue. Some of these things shouldn't have ended up in court. And I know for a fact, after the RPL, this was brought on by the practitioners who said there was no consultation, they don't want it. But we know that afterwards the practitioners were frustrated by the processes of now having to reconfigure the various tariffs for, at that time, I think close to 80-something schemes. So some of the processes are held back, not because it is not the right thing to do, but rather the process leading towards that. And that's what I'm saying, that there is a need for those particular dialogue. When somebody says there's a technical problem, and I'm saying even not from outside, the two legal advisors were not in agreement. But I don't remember seeing a process that says, is what the parliamentary legal advisor saying worth a grain of salt or something? I think those are certain things that need to be. I mean, there are many things that we will not maybe agree on in terms of where to place them. I mean, the issue of benefits, I can talk about your frustration about not being able to understand what's happening. Medical schemes determine benefits every year, and the process starts after conclusion of the first quarter. And the reason is that they want to see data from the first quarter and determine what has happened. And that process carries on until submission during August. So it's not an easy process, and we appreciate that there is no detail right now. But there seems to be a preemption of these processes by, for example, inclusion of Section 33, while we know it's contentious and speaks to benefits, because it talks about full implementation, comprehensiveness of coverage. While we acknowledge that at this stage it's too early to contemplate what is contained in the benefit. And those are some of the comments we're saying must be looked at. I mean, I like the correction around the Solidarity Fund. I think, isn't there a test for the strength of collaboration? That we fairly did well. And all the other corruption happened elsewhere, not in the process that we came together for. And that's what we are advocating for. I spoke about virtual pooling. There is minimization to an extent of risk. We might argue about the issue of efficiencies. But at times you have to make certain compromises for the bigger picture, because there are certain issues that come up when we try to maybe in your overhaul end up debilitating one system. We agree that medical aids are expensive, but there has been suggestions of how to correct that over time, whether you're talking from an HMI perspective, PMB review, introduction of low-cost benefit options. Now, all these things, unfortunately, schemes are not self-regulating. We have to make suggestions and pass them on to government for government to implement. And as players in the system, there are expertise that actually lie or come as a result of our being active in the system for a long time. And hence Dr. Mzukwa's lamentation of not being consulted. Because over and above calling for submissions, it would make sense to say, come to the table. I know I've been in some of the meetings you're talking about this, but mostly those are operational issues. They're not large-scale issues. We'll be talking about AROPS and fraud, waste, and abuse. But NHI is big enough for the department to say, Summer, let's have a discussion. We saw in your submission you are raising this. We don't understand it. We don't think it's relevant. Can you come and give us a view why it's important?
Thank you very much. Let's give...
Yeah, no, thank you so much.
Tuesday, and then what we'll do, I'll take a few questions from the audience, and then allow our panelists concluding remarks. As they said, this is a long game.
Yeah.
I think, by the time we get the board, there'll be a new government in 2024. No, I'm just saying a new government. I'm not saying there will be, and by the time the board comes in, it will be the new cabinet appointing that board, and then the implementation too. But I think the devil is in the detail. It's just uncertainty. Well, what next? Where to and where. And this has been a very robust engagement and interesting conversation. But Doctor, over to you, and then we.
Okay, Okay, thank you so much, Honorable Singh. I think the concluding statement from Nicholas is interesting when he says nothing in this bill is clear cut. And I think that's what we have been saying, that's what we've been talking about. But if I may go back to some of the issues that you have raised. First of all, I didn't expect, Dr. Crisp to be speaking on behalf of the portfolio committee, because I did specify that our consultation did not happen with the portfolio committee. So I didn't expect him to really appoint himself to that position of speaking on behalf of the portfolio committee. Now, yeah, I did. And the people that he's quoting, having met, those are my managers that I'm overseeing in summer. I know what they are doing. I know I get reports. They've met Crisp. They've met that one. I sit there listening to their reports. So I can't not know that my managers are busy out there. The CEO, they report to me. So I would know that. Yeah, the other thing is, when you talk about NHI, agreeing that NHI is not the only bill that is going to resolve all healthcare issues. And we talk about other acts that are already in place to address other socio-economic and environmental factors, social determinants of health. I have not seen them solving the water problem in the Eastern Cape, in my village. And I have not seen them resolving the problem in Hammanskraal. And those deficiencies are eating in the budget of healthcare. And I'm saying, you can have all these things that you're talking about, but if you don't solve other problems, you are going to have a problem. The minister and other people, they've been talking about the National Health Service in the UK. But when we debate, we must not use the UK as an example. But when it's convenient, they say it's been 75 years. We must look at the UK, not Dr. Crisp. I'm talking about the minister. He says, look at the UK. But what the minister is not saying about the UK is that the UK is collapsing. That healthcare service, we all know, it's all out there in the media. They cannot sustain it. Why? They have shortages of staff in there, dire shortages of staff. They are coming to some of my colleagues in Joburg to buy healthcare. They're coming to South Africa to buy healthcare. So, I don't want us to use examples when it's convenient for us. I think we must, if we are elevating this debate, and I like this thing of always correcting the debate. We are not talking about the need to reform. We all agree, all of us. We agree. So we must not rehash, things that, the private sector is saving 16%. This one is saving 84%, and all. We know, all of us. That's not the debate. The debate is in the solution. How do we do it? And we don't agree on how do we do it. And the how part is having to make sure that when it comes to, the protection of funds, we protect those funds. This reassurance, only by, the word of mouth, I think it's not enough for us. Those uncertainties are the ones that are causing problems on the ground. People are not sure of what is going to happen. By the way, let us remind, colleagues that, when we're talking about, those that are benefiting from the medical aids, those people, they've already paid tax to the state. It's like when you don't have enough security, you realize, hey, the SAPS is not trustworthy. Let me get a private security. Are you going to be blamed that you have a private security in your home because the subs is not working well? You must have private security. You can't rely on subs. Education. If you see that education is a problem, you're not sure what is going, you are going to seek private education for your kids. So I don't think I mean, it's not like you're paying for private education and you're not paying tax. Even this thing of being condemned, say those that are paying for medical aids, they must not then go back to the state. But they've paid tax. They are the funders of that system, by the way. Whether they choose to use it or not, it's up to them. Don't blame them when they go back and use it. They've paid for it through tax. So that's what we're saying.
Thank you very much. Thank you very much to our panelists. Colleagues, as I said, robust engagement necessary, and I think even the panelists will agree that this platform that we've created for you, you've been able to talk about more issues than otherwise in this platform here. So we're pleased, I think, that the outcome of this workshop so far. Tomorrow we're dealing with another speaker from the health sector, Dr. Anushka Kuvadia. She represents medical aids and things like that. So, but this is really enriching us. I'm going to take, colleagues, only 5 questions, because I think there were enough questions here. And I'll take 5 questions, right? And after those 5 questions, I will allow our esteemed panelists to make some concluding remarks, and we'll end this evening on the basis that we must continue talking. Dialogue, dialogue, and dialogue. Utata Matiba said that, and that's why we're enjoying democracy today, because of dialogue, even with the enemy at that time. But when we dialogue, we must dialogue with an open mind of trying to find each other and finding solutions, rather than saying, no, this is it, and that's it. Highway or no way? No. Okay. Right. So I'll take 5 hands. 5. Right. Number 1 is there. Mabaso. Deputy Chief Whip, number 2. Hey, I'm so happy. There's number 3. And questions, please. Questions, not statements. Number 4 there. So 1, 2, 3, 4. Is that it? Yes, for now. Where 5? Oh yeah, there's number 5. Yeah, we want the youth. We want to hear the youth. They need medical care. All right, let's go. Number 1.
Thank you very much, TG, and greetings to all the colleagues. But acknowledge the presence of the Honorable President, the caucus chairperson, and all other leaders that are in the session. I know, TG, I had joined very late, but I think there is one thing that is not coming out clear for me in the whole discussion. And I understand that Dr. Nicholas did allude to a fact that they are still going to clarify on what will be covered in the NHI, same as in the medical aid schemes, where it is not clear, and they're also not clear, meaning that the Parliament has gave the Department of Health a blank check to say go out and do whatever you want to do with the bill. But my question will be, I think as a person from Soweto that uses Bara, a hospital, as a means of accessing healthcare, and with the introduction of the bill, I think 2 years ago, I went for an operation at Netcare in Malbatin for my eardrum. So because those specialists are not there at Bara, to do that particular operation the way the private institution conduct that particular operation. So with the bill now, if it's being implemented, will we be able to access the same specialists that we are accessing in the private healthcare system? And if the answer is no, then why the introduction of the bill in the first place, if it's not going to attract the skill that is not provided for in the public health system? So that would be my question, TG.
And you all can answer, whoever. Number 2, let's take the 5 questions.
Thank you, Honorable Chief Whip, Dr. Mutudi, Dr. Mzukwa, and Dr. Crisp. Mine will be mainly to ask, is the NHI going to be decentralized at some point in time? I heard Dr. Mutudi and Dr. Mzukwa speaking about there are certain areas where they come from and casing all cases on merits, that if a certain province is dealing with certain issues of health, then that should maybe apply to that. Is it going to be decentralized within the provinces? And again, another issue that we are not raising, I raised it before on the previous panel. I do know that Section 27 of the Constitution says everyone has a right to access to healthcare and so forth, but we have an influx of illegal migrants that are coming into South Africa. Our infrastructure is not in a manner that will be able to intake all these, us as South Africans and also everyone that comes to South Africa. How are you going to deal with that situation? What are the plans in place to make sure, because even now they are benefiting from our healthcare. They go to these hospitals, they get the healthcare that we are all getting, and then it puts pressure because now South Africans are not taken care of the way they should be because of these illegal migrants. So if you can please clarify on that, because I feel safe that I'm on the medical aid because I know that I'm going to get a proper healthcare where I am. But now the NHI does not give me that ease of to say if the NHI takes off, then what is it that is going to happen? Thank you.
Thank you. Number 3.
Okay. Okay, I have two questions, but the first one is very brief. Would it be prudent for a political party like the IFP to come up and say, when NHI is being implemented and we are doing away with medical schemes or medical aids, will it be a better position to say, let us amalgamate all the medical schemes and give them the sole responsibility of administering the financing part or the funding part or managing of the money part? That's one. Number two, I think it was Dr. Mzukwa who actually touched on this aspect, but I think it came from at a very heated moment when he actually said that the people from the UK are frustrated from the system that they're currently using, which is the NHS, and they're coming to South Africa to access healthcare. And I've personally lived in the UK for some time, and one of the frustrations people are experiencing there is actually long awaiting periods. So if you want to go for an orthopedic surgeon, you may wait for a period of 9 months because of issues of human resources in that particular country. And then we get an industry that is emerging now, which for lack of a better word, I will term it medical tourism. So you find people from country X flocking to country Y to come and seek healthcare. Have we thought about that part? Because in South Africa alone, we are attracting about 1 million people from outside the country. I'm not referring to illegal migrants. I'm referring to people who are here in the country, who have the money, who will come to the country and pay for a certain medical procedure or whatever, access to medical care, and they'll go back to their country and they pay cash. And that also contributes to the GDP of this particular country. So have we thought about how that aspect of people who are not residents of this country, neither they are illegal immigrants who are coming to this country to seek healthcare, how are we then going to regulate or administer that part of the health system? Thank you.
Thank you very much. Let me just clarify the UK part. We use the UK just to set the scene, and because it's 75 years, and I was there two weeks ago and I saw this clip, so we didn't use it as a benchmarking or anything for us, but just to say, well, this is happening in UK, this is happening in Taiwan and other countries. So just to benchmark, get an understanding. Right, number 4.
Thank you very much. Dr. Chris just mentioned earlier in his presentation, because I'm just looking for clarity here, he said this is going to be one health system and not one state health system. So I just wanted to understand what is the difference between the two, because I was under the impression that this will be maybe overseen by our Minister of Health. In this case, does this then do away with maybe the current ombud system that we currently have? And just to add on to what Deputy Chief Whip said earlier, is that, as you guys mentioned, we are still learning with regards to this, and nothing obviously has been 100% passed. But I wanted to find out from you guys that what is the policy of countries that have successfully implemented the NHI bill with regards to illegal migrants? Are they serviced or are they not serviced? Because as our Deputy Chief Whip did say, that there's a big chance that the very same system that we are trying to implement is going to be overburdened again. And just finally, lastly, according to you panelists, so just to find out from you panelists, is that we're going to hear people say we are for it, we are against it. In your opinion, what are the main issues or the main sticking points to the public and the private sector really not finding each other? Thank you.
Thank you, number 4, number 5. Sorry, I'm calling your numbers. Yeah.
Greetings to the house at large. My name is Sigobile Mkwanazi. I'm from Ward 40. So my question is, I heard people speaking of illegal migrants, but in South Africa we have a number of people who don't have IDs. So when the NHI starts implementing, how will they assist people of our country who don't have identity documents? And then my other question is, will the NHI fund the unemployed? Because we have a problem. I heard the Taiwan doctor, I think, speaking of saying when they calculate the premium, they say salary times premium rate times contribution and number. So the salary part is the important one. If there's a large number or high number of people unemployed, if you're going to count the premium by the unemployed people, by the salary, and there's a lot of people who are unemployed, how are you going to do that? Thank you.
Oh, thank you very much. Right. Esteemed panelists, in any order. You're ready, Dr. Chris? And if you can answer, and then give us your concluding remarks.
Okay, thanks. I'll try and be short. Thanks very much for the opportunity. So there's no blank check given to officials or anybody from the first question. What the benefits have to be signed off by a benefits advisory committee. So the benefits advisory committee must then submit those, like we do at the moment with regulations for medicines, etc. They all go to the minister and they get published in the Gazette, they get commented on and they get signed off. There are no blank checks, there are lots of checks and balances. So thanks for that comment. Will you be able to access the same specialists in public or private? Yes, absolutely. That's the whole point. The whole point, and the bill says very clearly, if you see me and I am not able to care for you at where you came to see me, I must refer you to somebody who can care for you. And if you get to that next point and they can't care for you, they must refer you. Whether they refer you to a public or a private, take the Springbok rugby player now who's been in a coma for a couple of weeks or whatever. He was cared for in Steve Biko, not in the private sector, because that was the best place for him to get the care at the time. So the answer is very definitely yes, you will be able to access them, but on referral. Will NHI be decentralized? I'm not quite sure what the term decentralized means, but everything is decentralized. All services. The NHI bill goes to great extents to say that there must be managerial autonomy at the point of service, which is a problem in the current public health system. A private hospital manager has far more authority over appointing people, buying stuff, and so on. We want that decentralized, and it will be across the whole country. Now, if you worked in, I presume, rural KZN would be an example. I worked in rural Limpopo for many years. There's nothing else there. So what we want to do is use what's called strategic purchasing, and there are various options, to shift the care into those areas where there aren't. We want to use the GPs, who are completely underutilized in our current system. One thing we agree strongly on. We don't all disagree. We all know one another quite well. There are some things we disagree on and others we agree on. But the GP needs to be put back in the center of the health system where they were back in the day. So we agree on that. I'll deal with the illegals as one lot to say, during COVID, we identified 3 million undocumented people in South Africa, working with church groups and other NGOs and so on. About 2 million of those are South Africans. And about 1 million of those undocumented people, more or less, 1/3, are illegal, they're not supposed to be here, they don't have any papers. We put a system in place during COVID that we issue an ID, not the Home Affairs ID. We issue an ID, a health ID, to undocumented people. But it's easy to defraud even Home Affairs. So we are all moving towards biometric, where we can make sure that I am me and you are you, so that I don't give you penicillin because I think you're somebody else. We, at the moment, the health department does not make policy on migrants and on illegal and foreigners and so on. Home Affairs makes those policies, together with Parliament, of course. But we are signatories to international agreements. And so in the health department, we will stick to the international agreements. And the international agreement says you will look after all children. Children belong to the world, they don't belong to a country. We will look after them. We will look after all pregnant women. Now there's a problem for us, especially in Limpopo, because people come across to deliver and leave and across to deliver and leave. And we need to go into international relations with our neighbors to deal with those. It's a complicated space. It's not only a health space, as you know, with the trucking incidents recently and so on. I think I'll leave you to talk about medical tourism, and I won't respond to that one. And I'll leave you to talk about amalgamation of schemes and whether that might be an option or a good idea. The one health system, not one state health system. So the position that the EFF took when they rejected the bill was that they don't want any private providers, they don't want any private funders. Everything must be taken over and run by the state, which is what the NHS did in 1948. We are not going that route. We respect that people need their independence and their autonomy to run private practices, and we respect that private hospitals run efficiently and may be there. In fact, the relationship with the private hospital groups is extremely good, and we are looking for ways to work together given the current legislation. It'll be easy once the NHI legislation goes, but right now it's quite difficult to do it. So one health system where all of us, whether you work for yourself, whether you work for a private company, whether you work for a provincial department, shouldn't matter. All that matters is the patient. And if I'm the patient on that day, I must just know that you will look after me and I won't pay at the point of care. I've contributed. And that brings us to the unemployed people, which is the last comment I want to make. And that is that the whole purpose is to give services to unemployed people in the same way as I get my health care. Just because I'm unemployed or I'm poor or I look a certain way or I identify in a certain way is not a justification for denying me health care. Poor people contribute to tax. We need to acknowledge this. Yes, I pay a hang of a lot of tax as a well-employed person. But the Gini coefficient, that is the difference between the wealthy and the poor, is very wide. So I must expect to pay more taxes. I don't have a problem with paying tax. I get upset when I don't get services for it, but I don't mind sharing with those around me. That's what we did during COVID as well. So poor people pay tax in very discriminatory ways. Everything they buy that's not VAT, zero rated on VAT, they pay VAT. Anytime they get in a taxi, they're contributing to the petrol levy. Every time, just about any time we breathe in South Africa, there's some tax. And even poor people feel that burden, but they feel it heavier than I do. Because it's a greater proportion of their spending that goes into transporting them to hospitals and trying to access the services. So the short answer to your question, ma'am, is yes, very definitely. We will not discriminate against any one of the 61 million people. That's the intention. I don't know who wants to go next.
Thank you, Doctor. Will that be your concluding remarks as well?
Yeah, that's my conclusion. So let me just say thank you very much because I won't get a chance again. It's been a very fascinating discussion and I really appreciate the opportunity.
No, thank you very much, Dr. Chris.
I just wanted to touch a bit on the issue of migrants. We agree that, you know, it is very much possible that even if we go through the NHI route, we're still going to have the question of migrants. But we have made, as the South African Medical Association, when we made our submissions to the portfolio committee, we did come up with what we thought would be some solution to it. To say that as the Department of Health, let's keep data. Let us know who is coming from where in terms of the migrants. Keep that data. Then SADC must have a discussion around how do we finance those that are coming in the country. We thought that would be reasonable enough. To say, we're not going to chase you away, but your governments must contribute to us, instead of shouting at patients. Because what we have seen now is people are shouting at patients. That thing, we condemned it because it's wrong. You can't be shouting at a patient because Mugabe or whoever did something else in his country. It has nothing to do with the migrant. So I think that that's the one thing that we suggested. About the issue of long queues, yes, we are aware that in the UK, there's about 7.4 million people are waiting to be done procedures. It takes about 3 to 6 months to get access. Hence, others are coming to other countries like South Africa and anywhere else, to buy services. And I read a story about a lady who was also using his services in the UK to, obviously to buy private care. So I'm saying, this thing of the challenges that are there, I know it was, we don't want to use it as an example. And we avoid all the things that are failing as examples. We can't use that one as well. So it's fine, we agree with that. So I think what we need to do then is, to exclude the UK in all our engagements and talk about something else. Thank you so much.
Thank you.
Thank you very much. I'll touch on a few questions. The issue about amalgamation. I think a proposal to amalgamate all schemes will be no different from establishing the one fund. The only difference would be the administration or control will be in the private sector. And I don't think that would fly in the eyes of the department. I, however, think that there's probably models that we can find in between what has been proposed and what can work. In some circumstances, other commentators have even proposed that you could, at a district level, issue out requests for proposals for administrations that would be overseen by the fund and allow even the medical aids, for example, to tender for those. It might be extreme to say, or is it 52 districts open up for such a proposal, but some of these have actually found patches in, and I remember listening to somebody from Spain who's saying out of the districts that they had, there is one district that is run by a private entity, and they're given, I think, like a 10-year contract or something like that. But the accountability processes are quite stringent to the extent that even the margins are tightly regulated. So there is probably a solution somewhere in between what is being proposed and then also your proposal. But we can only find those when you put our heads together. The issue of medical tourism, I guess it does not wholly fall under the proposed bill, in that migrants or tourists that come into the country are expertly excluded from the definition of a beneficiary of the fund. One could then argue that it's one way of keeping the private sector alive. But before I think we get excited, Dr. Mzugwa, when the NHI is operational, we might not have capacity to look after other people because there is underutilization of private sector facilities. While from an economic point of view, I think it looks pretty. It means that we will have to ramp up our services. It means we have to make sure that we don't have practitioners leaving our borders to other countries for purportedly greener pastures to be able to assist with any such request. But medical tourism has been found to be a boost to the economy. If you follow what's happening in India, for example, and then South Africa be having the kind of infrastructure, etc., that we have, we are actually better off than a lot of our African compatriot. So it's something that maybe we could look at from the private side as a way of making sure that the private sector remains relevant. The issue around the differences that we have between the private and public, I think we've spoken about the issue of the trust deficit. That is a huge issue. I remember during the lockdown, we organized a dialogue, and then we asked one commentator to speak on how do we keep politics out of NHI, and his answer was, we cannot keep politics out of NHI because the whole issue of healthcare is political. Having said that, it is so issues of ideology are deep-rooted into the discussion, and often that puts us at polar ends. We've just spoken now about the EFF, who are going for full nationalization, and I'm certain that the IFP has got its own position, so does the ANC. And those saw divisions not just among the public and private, but also within the state. But the posture, I think, that we must assume is that we must put the user, the end user, the health beneficiary, at the center of all debates. Because once we do that, it actually eliminates a lot of the challenges. That it will not correct everything, but it will go a long way. And I think just in closing, that the discussion will never be easy. We're talking about something personal. We're talking about scant resources. So at some point we have to accept that there is some rationing. It won't be different from a discussion that you'll have with your daughter or son on a Friday night when they want to go out partying. But there is some sort of regulation that you have to apply, and also accept that there is rationing. I advocate strongly that there must be partnership and collaboration, and shutting out one sector completely, I think we're going to fall short. Thank you very much, Honorable.
No, thank you very much. I think that was a very good way to end, that there must be, and I think that's our philosophy, that there must be partnership and collaboration. You see, when the elephants fight, the grass gets damaged. And we don't want the grass to get damaged at all, because we all have an interest in the grass. So we hope that these major role players can continue the dialogue, find each other, and hopefully when something goes to NCOP stage in terms of the schedules and the legislation, there could be some amendments that will address some of the kind of risks that we have identified. I now want to invite Honorable Mahlengwa, who is our member on the Portfolio Committee, to come up and present a little token of appreciation to all our panelists, just as a way of saying thank you to them for your time. Thank you, Dr. Mzukwa, for allowing us to change your flight. And I'm sorry, the only flight we could get for you is 2030. Yeah, so, but otherwise, it's fine. So, Ma, in any order, I think you know Dr. Crisp first, so you give him first. You meet him all the time.
Thank you very much, our Chief Whip, our President of the party, all protocol observed. Let me thank you and repeat it, thank you, but I lose an opportunity to Dr. Zuma because I have an issue of the ladies, 90 ladies in KZN, where they sterilized, not consulting them, not explaining to them what are they doing, or they are going to bear their fruit of their womb or not. But I think there will be a time. Thank you very much.
Thank you, Matlangwa, and you can hand over to Dr. Matudi, Dr. Crisp, and Dr. Mzugwa. Right, we thank you, panelists. You see, there are friends in the committee. That is why Minister said to me, he said, hey, the minister said to me in the lobby, but hey, Matlangwa was agreeing with this and that and that. Now why you came and changed this whole story? I said, no, we reconsidered.
Sorry, that interaction was that Matlangwa knows that I do not accept any gifts because I'm a public servant and I'm trying to make a point about receiving gifts. I would like you please to donate this to somebody of your choice that can use it very effectively, please. And I thank you for the gesture, but I want to make this as a gesture back. Thank you so much.
Thank you. Just because you said that you are non-political.
No, we respect that. Colleagues, as our panelists go back, I'll just make the announcements for tomorrow. Please, 8:30, please, colleagues. If you're here between 8:30 and 8:45, we start at 9. Tomorrow, we don't want what happened today, right? Let's start at 9, and we want to try and finish a bit earlier tomorrow because some of us are taking flights, etc., etc. So after this healthy discussion today, let's drink water tomorrow because we're starting with water. A discussion on water, then health, and then we're going to sit and take some resolutions on the way forward, and we're going to have a little political discussion amongst ourselves. So, Pastor, where's Pastor Ruben? Please come forward. Any other announcements from our team? Thank you to our wonderful team from Cape Town and Gauteng. I mean, yeah, they've done a tremendous job in ensuring this is a success. Thank you to our technicians there for all the great job they are doing. Thank you to Monte Casino for all the wonderful facilities that they and thank you, Mr. President, for being here at 8:30 in the morning. You are still here. I know you are coming tomorrow and possibly on Sunday as well. So we really, really appreciate that. And Mang Kwanyana, unfortunately, unwell, but thank you very much. We're just going to do a concluding prayer, and then we'll allow the leadership to have their tea and their snacks, and then Gauteng leadership, I want to see you, okay, in the room there. Thank you very much, Pastor.
Can I ask us to stand as we close in prayer? Lord, we thank you for a fruitful day. We thank you for the intense discussions and the progress that we have made today under your covering. Once again, we are grateful and thankful for your leading and your guidance. We thank you for this day that has been well spent. We pray for those that will be traveling, that you grant them safe traveling. We also remember Mam Kwanyana now, who's not well. We pray for your healing hand over the body. We thank you for the rest of the evening. May it be a blessed one. In Jesus' name, amen.